It is a great pleasure and honor to introduce the moderator of the day for the Clinical Imaging in Glaucoma Diagnostics webinar. It is none other than Mrs. Jemima, the optometrist, senior lecturer of Sri Prakash Institute of Optometry, which is now called Agarwal Institute of Optometry. She has graduated from Elite School of Optometry in the year 1999 and then did her master's from Shankara. She is also a fellow of ASCO on low vision care. She has immense experience as clinical optometrist at Shankar Nethralaya, and then for the last 1 decade, she is working as a senior lecturer in Agarwal Optometry School of Optometry. So now we welcome Jemima as a moderator. Madam, the forum is yours. Please take over. Thank you.
Thank you, sir. So a very warm good evening and welcome to everyone gathered here. It is great to have to update our knowledge and increase in our knowledge in every field of optometry. And today is a very interesting topic, which is imaging in glaucoma. The thing is, glaucoma can be fully, all the diagnostics can be done exclusively by optometrists, and it is a very important topic, and we are very pleased to have the best person in that topic speaking to us, who is none other than Rashima. Before I go on to introduce Rashima, I would like to thank OATN team for this opportunity given, and OATN is doing a fantastic job in bringing so much of knowledge easily approachable for everyone, and I'm sure all the students and optometrists are benefited by this. Thank you, Kumaran sir, Jyoti Balaji, thank you, Pungoday ma'am, thank you, Purnima, and thank you also KK for being in the panel. And now a little bit about our superstar of the day, Rashima. So Rashima Ashokan is working as an assistant professor at Allied School of Optometry. She leads the occupational optometry services of Shankar Nethralaya. She has done extensive research in glaucoma, and we cannot find any other best person to share her knowledge with us to us. She has also published many many of her research works in many international peer-reviewed journals, and she has also presented in various conferences. She's also received the Young Scientist Award and Golden Jubilee Award from the Indian Association of Occupational Health. So we welcome Rashima. There's much more to be said, and more than that, we would be very happy to listen from you. So sit back. Please do take a notebook and pen and try to jot down notes because these things are very essential for each and every one of us. So a warm welcome once more to Rashima. Over to Rashima.
Thank you, Jemima, for a wonderful introduction, and thank you, OATN, for inviting me to give the lecture on clinical imaging in glaucoma diagnosis. So is my slides visible?
Yes.
Okay. Yes. So before I start with clinical imaging, I just wanted to tell you that I'm going to keep the lecture very simple and basic on the glaucoma diagnosis, and I'm not going to talk anything about the progression analysis with the imaging tools. So it is going to be kept very simple. So probably in the future lectures, we can even look at how the glaucoma progression is analyzed with these imaging tools. So as an optometrist, we play a vital role in screening and diagnosing the condition. So there is also papers that says that optometrist, ophthalmologist, the agreement in diagnosing the condition and also recommending for the treatment is very good, which means that we have a greater responsibility of identifying or diagnosing this particular condition and refer them to the ophthalmologist for appropriate care. So how do we do that? So we need to have appropriate knowledge and acquire the skills to diagnose the condition and refer them appropriately so that the patient is at the right hands. And we also play a very important role in co-managing the condition so that the patient comes back to us for a follow-up. And if we have to do the diagnostics, it is in our hands. Most of the diagnostic tools for glaucoma has been handled by optometrists, and the ophthalmologists are helped by the optometrist in this particular. So what are the essential skills in glaucoma diagnosis? So it is the comprehensive eye examination, slit lamp examination, and also the measurement of intraocular pressure by any means of contact or non-contact tonometry, and assessing the anterior chamber using the Van Head grade, gonioscopy and pachymetry if possible. And next comes the posterior segment, this optic disc assessment, and visual field assessment, and the topmost is imaging. That is what we are going to cover today. So why imaging? Clinical diagnosis always needs an expertise. So you must be very, very sure of the skills in diagnosing the conditions. So, and it is very essential to follow up these patients because it is actually a progressive disease. So you need to follow up the patient so that the patient doesn't go blind. If you rightly target at the right moment, you will be saving the sight of the patient. So it is important to image so that we have early diagnosis possible, and it helps in the follow-up of the patient, and also it eliminates an observer bias because most of the imaging tools give some quantitative measurements so that the follow-up is made easier and there is less amount of bias. So the major principle in which the imaging tools works are it has a greater penetration. Either you go wide, like you want to see a wider area of the eye, or you take the surface analysis, that is the topography, or tomography is like slicing down and looking into the sections. So these are three major important aspects of imaging. The common imaging techniques, especially used for glaucoma, I'm talking about the non-invasive techniques here, is the anterior segment OCT and pentacam for the anterior segment analysis. And for the posterior segment, it is the fundus photography and confocal scanning laser ophthalmoscopy like CHARTI and optical coherence tomography. So I'm going to cover all these aspects in the forthcoming slides. First comes the anterior segment OCT for glaucoma diagnosis. So what an anterior segment OCT does? So it images the anterior segment. So you have the cornea, the iris, and the anterior lens surface, which can be imaged using an anterior segment OCT. So what it gives us the anterior chamber depth, the corneal thickness, and you can also measure the angles. So in cases where the patients have suspected to have narrow angles, so we do the gonioscopy, and it is sometimes not very accurate in the sense if you're looking at a follow-up, you should be in the same hands. If not, then there will be a possibility of observer bias. If an ASOCT is done, so you are very sure of the angle measurements, and you can even look at what happens in the future, whether the angle is nearing or not. So you can measure the angles here. And also, in cases where in primary angle closure disease, where peripheral iridotomy is done, this tool can be helpful in imaging the PI and see whether the PI is patent or not. So in cases where the cornea is not clear and you're not able to assess the patency using a slit lamp, this tool is very useful. Next, the ASOCT in filtering surgeries. So surgery is done. You want to assess whether the bleb is patent or not. ASOCT is there to help you out. And also these surgeries like valve implantations for glaucoma, which is implanted in the anterior chamber. So this is a valve, but this is not patent because there is a small block here because of tissue. So also you can look at whether the valve is touching the corneal endothelium. Is it away? Is it at the anterior chamber? Where is it located? All these things can be assessed using an anterior segment OCT, and this is completely non-invasive, so it is very, very helpful in the glaucoma management. So this is again the Ahmed the glaucoma valve, where it is in the anterior chamber and it is a patent valve. Another case, this is a case of malignant glaucoma, where you could see there is an aqueous misdirection. Because of that, the lens is pushed forward and it is almost a flat AC. So because of this, in these conditions, the cornea will be very hazy. So it is important to look at the anterior chamber, how it is. So definitely this tool is going to. So anterior segment OCT plays an essential part in diagnosing the glaucomatous condition, and also mainly in cases where the cornea is decompensated. The anterior segment OCT, the whatever pictures which I have shown was from the Bisante OCT, and an advanced technique with the principle of swept source is the Cassia OCT. Cassia also has the quantitative measurements inbuilt in the OCT. So the quantitative measurements here are measuring the angles and give some information about the lens vault. And also it is very useful in evaluating the iridotrabecular contact and any corneal contact. So it is called as a virtual gonioscopy. So this video shows the anterior chamber, how it is aligned. Is there any contact of iris with the cornea? And this is evaluated using a Cassia OCT. So this is an advanced anterior segment OCT which is available. So other than the ASOCT, Pentacam, which is usually used in corneal imaging, which gives the topography, it is also used for glaucoma diagnosis because it gives the anterior chamber depth. You can also evaluate the anterior chamber angle with the Pentacam, and also it gives the anterior chamber volume. So Pentacam is also used in clinical imaging for glaucoma. So before I move on to any other imaging tool, I just wanted to present a case. So this was a 30-year-old female who came for a regular examination, and there was no specific complaints. And she presented with a family history of glaucoma in her mother and grandfather. The rest of the history were normal. So refraction was done, and the patient was seen to be a myope, and there was no change in glasses. Her vision was 6/6 and N6. Slit lamp examination was completely normal with a Van Herrick grading of 4, and gonioscopy was done, and it was open till ciliary body band. The intraocular pressure was normal for the corneal thickness, so it was 20 and 21. So what do we do next? As an optometrist, what is our role here? There is a presence of family history of glaucoma, right? So what do? So we just counsel the patient saying that you have a family history, you should be doing an annual examination, and send the patient back, or refer the patient to an ophthalmologist. Because there is a family history and the rest of the things were normal, still you wanted to have a complete examination, so refer to an ophthalmologist if we do not have a complete facility of the imaging tools, or if we have some facility, look out for the structural and the functional loss. So if you have a fundus camera in the clinic, so what you can do is image the optic nerve head. So this was the image of the patient. You could see this was a picture of the right eye and the left eye. Just seeing the image, anyone could say that there is a difference in the cupping between the eyes, that both doesn't look similar, right? So which means it is little suspicious. So in case of suspicious optic nerve head, what we evaluate is the structural damage using an OCT. So the patient was advised for OCT, and in the OCT, there were some red signs. Probably in the future slides, I will explain about how to interpret the report in detail. But for this particular case, there was some red sign here, which is suggestive of some damage. So the patient was advised for the functional loss assessment using a static perimetry. And the functional loss showed this. The patient had a nasal step with the visual field. And there was also some amount of damage which was seen in the left eye. So this patient, if seen in the clinic, just for the family history and rest of the things were normal, would have been sent just with the awareness of glaucoma. But if we had evaluated using an imaging technique or using a functional assessment tool, we would have picked up the condition. So I just wanted to show you this slide, which is essential. Almost all the glaucoma practitioners would definitely show up this slide, just explaining about what glaucoma is. So from a normal, how the person goes to blindness is explained in the glaucoma continuum by Wainwright. So there is some amount of cellular loss which is present, and there is a nerve fiber layer defect, which is detectable using imaging tool. Until all these condition happens, the patient is completely asymptomatic. So there is no signs there is no symptoms from the patient until the patient has some amount of structural functional loss with the visual field. So what happens here is there is a structural loss which is evident. So if we optometrists detect the person or diagnose the condition at this particular stage where some amount of structural change is visible, then we are going to diagnose the condition very early and going to give a visual prognosis to the patient in expanding the lifespan of the patient visually. So the patient is not going to go in for blindness. So this is where the optometrist's role is in clinical imaging for glaucoma diagnosis. So why it is important to evaluate the optic nerve head? What happens with the optic nerve head is the retinal fiber line loss is present, and that is going to be the first sign for glaucoma. So if we carefully evaluate the optic nerve head, we can even diagnose a preperimetric glaucoma and follow up the patient. Also, in patients where they are not able to perform the visual fields reliably, this is the only technique which will help the clinician. Also, in cases where there is ocular hypertension, the person is progressing to a glaucoma, that can be assessed with the optic nerve head evaluation. So this is a picture of a normal optic nerve head, and the right side is a picture of a glaucomatous optic nerve head. So how do we say this is normal and how do we say this is glaucomatous? So for optic nerve head evaluation, what we have is the 5 R's. The 5 R's are the spiral ring or the disc size evaluation, neuroretinal rim, retinal nerve fiber layer evaluation, region of peripapillary atrophy, and the region of optic nerve head hemorrhages. These are the 5 R's which has to be evaluated for the optic nerve head. So let's see in detail. So what we see over here is the 2 optic nerve heads. Both are not similar, but what is similar over here is the disc diameter of the left side picture is very similar to the cup diameter of this right sided picture. What I mean by this is eye, which is shorter, and eye, which is longer, with the larger optic nerve head. You have to evaluate completely different. Because if we don't analyze the refractive error and account it for the changes, then you're going to misdiagnose the condition. The refractive error assessment in any of the imaging technique is very important, not only for looking at whether the eye is myopic or hyperopic. It is also important to enter the magnification, enter the refractive error to correct for the magnification factor for the instrument. Okay. So here, let's see. Almost all the eyes will have about 1.2 million RGCs, that is the ganglion cell fibers, which is exiting out of the eye. So all these fibers should get out of the optic nerve head to reach the brain. So if you have a very small disc, all the fibers which is exiting out of the optic nerve head will be very tightly packed. If you have a larger disc, it will be loosely packed. That's the only phenomenon here. So in case of larger disc, it is loosely packed and they will have a larger cup. If it is going to be a smaller disc, it is tightly packed and they will have a very smaller cup as in this picture. So a hyperope with a smaller eye with a smaller disc will look like this, and a myope with a larger disc will look like this. So if you see a 0.5 cup to disc ratio of in a myope, it may be normal. But the same thing, a 0.5 cup to disc ratio in a hyperope with a smaller disc is not normal. It is really an alarming sign. So how do we evaluate the cup to disc ratio? Let's take the example of an egg. Okay, the outer covering of the egg is these, say the disc border or the disc diameter can be measured. And what is there in the white is actually the neuroretinal rim, and what is there in the egg yolk is going to be the cup. Okay, so we are going to look at the rim and the cup. So when compared to the disc diameter, how much is occupied at the cup, by the cup? If you take this as a 1 rupee coin, of this 1 rupee coin, how much is occupied by the cup? Okay, so how do we evaluate the cup? So the cup is never evaluated with the color. If you increase the flashlight in the fundus camera, you will go wrong in evaluating the cup. So it is important to look at the contour of the blood vessels exiting out. So what you see is, just see where the vessels are bending. So this is where you have to mark the cup. So if you do that, this particular image will have almost about 50% of this 1 rupee coin. So it will be a cup to disc ratio of about 0.5. So this is how we evaluate the cup to disc ratio. And we looked at the scleral rings, that is the diameter. So why it is important to look at the diameter is, when you do a cup to disc ratio assessment, a 0.5 in myope need not be the same as a 0.5 in hyperope. 0.5 in hyperope may be more alarming than a 0.5 in a myope. Next R is the neuroretinal rim. So the white part of the egg. So the white part, usually the superior and inferior are thicker when compared to nasal and temporal. So you have a larger or the thicker rims in the superior and the inferior folds, right? So this is because the arcades which are coming, the nerve fiber bundle is actually exiting here. So this forms the thicker part. If there is any loss, this thickness can come down. So usually a normal eye will have a pattern of ISNT, isn't a rule, which means inferior nerve fiber bundle is thicker when compared to superior and then nasal and then temporal. If this rule is lost, this is a sign for glaucoma. So inferior here is actually almost equal to superior, which means there is some amount of thinning which is present, and there is also a concentric enlargement which is seen here. So this is a sign for glaucomatous damage. So we looked at the scleral ring and we also looked at the neuroretinal rim. Now going to the third R, that is retinal nerve fiber layer. So as I said, the arcades are the superior and inferior arcades exit out here, and you will have a bright reflex from the arcades arrangement. If there is any loss, the bright reflex is absent and you would see as a dark band. So this dark band here in the inferior is suggestive of some amount of nerve fiber loss. So there is some amount of nerve fiber loss in the inferior part in this particular picture. So this loss has to be documented. So if you see a dark band suggestive of glaucoma, you will also see that the blood vessels are more thicker and more visible when there is a loss. So you can see the blood vessels much better if you see a dark band there, suggestive of glaucoma. The next one is the region of peripapillary atrophy. The peripapillary atrophy, many of us would have a peripapillary atrophy, which is a hyperpigmentation of closer to the optic nerve head. This hyperpigmentation can be seen in most of the myopes and many normals too. But if you see a beta atrophy, which is like very closer to the optic nerve head, and you are even able to look at the choroid, then that is a sign for glaucoma. So this particular beta atrophy is not present in normals; it is only seen in cases of glaucoma. If alpha atrophy is seen, that is normal. If beta atrophy is seen, that is abnormal. The fifth R is the region of optic nerve head hemorrhage. So you see a classic sign of splinter hemorrhage in case of normal tension glaucoma. So the splinter hemorrhage is like there is some kind of tear. This hemorrhage present on the optic nerve head is a sign of glaucoma. So there could also be a continuous nerve fiber loss alongside of the hemorrhage. This is a classic sign of normal tension glaucoma, and there is a possibility that it could regress. The hemorrhage could regress, but the nerve fiber loss which has happened over there will not be. So you should be evaluating for the hemorrhage, and sometimes it will get regressed. So when we have a fundus camera in the clinic, so we can image the optic nerve head. And there are also tools such as planimetry tools which could help to get the quantitative measures in the fundus camera. So most of the fundus cameras now come with these quantitative measures, like plug in your optic nerve head image there, it gives some information like the disc area, cup area, whether it is glaucomatous damage present or absent, to aid the clinician to appropriately diagnose the condition. So this is all about the optic nerve head evaluation using the fundus camera, which would be more ideal for the clinicians if you have a fundus camera in hand. So how do we evaluate the optic nerve head for glaucoma diagnosis? The next comes in imaging tool, like which uses a confocal scanning laser ophthalmoscopy principle, the HRT. So HRT takes sections of the optic nerve head and it puts together everything and gives a surface topography. This is the report of a HRT. So when you look at the report, one of the three important things you have to evaluate is look at the sectors, how it is, and look at the nerve fiber arrangement, how it is present, and also the which is in red in combination with the Moore-Fields regression analysis. And next comes the stereometric parameters, which is the quantitative measures here. So to aid the clinicians diagnose it better, we have the color-coded information over here. The green tick means it is normal, and a red cross means it is abnormal, and an yellow exclamation means there is some amount of borderline defect which is present. So these sectors just say the supratemporal, inferotemporal, nasal, temporal. So what happens in these quadrants, whether it is normal or abnormal? Next comes the nerve fiber layer arrangement pattern. So we looked at the neuroretinal rim, right? So we were talking about ISNT rule, that is ISNT. The ISNT is usually followed in the normal. If it is not followed, it is a sign of glaucoma. So what this graph is almost all the imaging tools of the nerve fiber, the neuroretinal rim for glaucoma will have this kind of pattern arrangement. That is T, and you have the T is for temporal, superior, nasal, and then again inferior, and then go back to temporal. So it is a 360-degree arrangement, and in the 360-degree arrangement, how is the thickness of the neuroretinal rim is what is assessed here. So usually what we have, it is a double hump pattern, because superior and the inferior are the thicker when compared to nasal and temporal. So the temporal forms the lowest form here. If this double hump pattern is lost, as in this particular image, it is a sign for glaucoma. So next is the quantitative measures, that is the disc area, cup area, rim area, and volume. All these things are evaluated, and it is given as a quantitative measures in HRT. But what happens here is, if you have a tilted disc, in that case, you may not be able to get the accurate value with HRT. And all these data points are compared with the age-matched normals, and the normal range is given over here. If it is not present, then you cannot use this particular tool to evaluate it further. So the next important aspect of HRT is looking at the Moore-Fields regression analysis. So it takes all the sectors and say globally, putting everything together, whether this person is normal. So cross means it is abnormal. And looking at the temporal, there is some amount of loss which is present. So it's a borderline defect. And supratemporally, it is a defect which is seen. And infratemporally, it is normal. And nasally and supranasally, it is abnormal. So inferior. So this particular patient, inferior part is fine when compared to the superior and the temporal region. So this is what the Moore-Fields regression analysis gives in HRT. So HRT report is very simple to interpret, but you should be very cautious in looking at the disc area, because if it is going to be a larger disc, this report may not be helpful. But if you have the patient tested with HRT, you can actually have that as a baseline and follow up the patient with HRT alone, so that in the follow-up, you will see whether the change is present when compared to the patient at the baseline. So for the follow-up analysis, it is definitely useful. So nowadays, what we have, the whole world is behind this OCT. So earlier, OCT was having a lesser number of scans, A scans built up, and this is how the image was. It's completely pixelated. But what we have now is very nice arrangement of these sections, and we could even look at the choroidal vasculature. So this is how the OCT reports are present presented today. So I'm just going to explain how do we interpret the OCT. So what we have here is the patient parameters, and next comes the quantitative parameters like what is the average RNFL thickness, what is the superior thickness, what is the inferior thickness, what is the disc area between right and left eye. And it also has a color coding which is very similar to what is in HRT. Most of the imaging tools follow the same protocol. Red means abnormal, yellow means borderline, green is normal. The next here is the nerve fiber layer arrangement. So as I said before, the arcades forms the thicker bundles, right? So in the nerve fiber, what we see is a hourglass pattern because the superior and inferior should be thicker. But in this particular picture, you could see that down here in the left eye, it is not thicker. Thinned out region is usually seen as blue part. If it is thicker, it is seen as a red and yellowish because it is a warmer color. So thicker means it is red and yellow. Thinner means it is blue. So more towards the blue is abnormal in case of nerve fiber layer arrangement. What you should look for is the NFL deviation map. So how is the person deviated from the normals? So looking at this particular graph, you could understand that there is lot amount of damage because red means it is damage here in NFL deviation. How much it is deviated from the normal is what is quantified here. You could see there is lot amount of damage in the left eye when compared to the right eye. Next is the neuroretinal rim thickness map. Very similar to HRT, we should be seeing a double hump pattern. But in this particular picture, you're not seeing a double hump pattern at all here. So what is lost is in the inferior part, you're seeing that in the almost in the red region. So which means that the person has NFL loss and the rim is actually getting thinned out. Okay. So these are the important things which we have to evaluate in an OCT. It also gives a sector. Like in HRT, it was dividing into 6 divisions. You also have this as sectors for 4 quadrants. So how is superior, inferior, nasal, and temporal in both the eyes. The color coding is very, very similar to HRT report. And it also divides the optic nerve head into different clock hours and gives the color coding here. So for glaucoma evaluation in OCT, so you have to use the scan for RNFL and ONH using an optic disc cube. Also, we can evaluate the ganglion cell complex using OCT. So what it does is closer to the macula. So it evaluates how much is the ganglion cell complex density is, by how much is the thickness. If there is a thickness loss, like in this particular image, there is a thickness loss which is present. It just suggests that the ganglion cell complexity is reduced, and there is a possibility that the person is going for the advanced glaucoma in this particular eye, and there is some amount of loss which is present, and both the eyes are not symmetrical. So just to brief you on, because on OCT scans, we have different protocols: optic nerve head analysis, and retinal nerve fiber layer analysis, and macula ganglion cell complex analysis. So what the best parameter to be evaluated is, in case of optic nerve head, it is the rim area. And in case of RNFL analysis, you have to look at the inferior part, inferior nerve fiber layer. And in the cell complex, we have to look at the minimum GC IPF thickness. As in any kind of imaging tool, this is also not very good with tilted disc, but this is much better when compared to the HRT with the advanced techniques now. The advanced techniques, even it eliminates the motion artifacts, because if you look at the earlier tools, the pixelations, if there is a small amount of eye movement, you could lose large amount of data. But with the advancements now, which has a lot amount of scans, that is almost about 400,000 scans, you will be able to look at each and every minute sections in the OCT. So just to have a clinical correlation, there was a patient who had a cup-to-disc ratio of 0.75 with the inferior slit effect, and there was no changes in the perimetry, and this is what the disc is. And when OCT was done, this is how the report was in the RNFL file. So you could see here, this double hump is now lying in the red region. All other things are in the green region. So only the inferior part that lies in the red region. Even the sector shows there is some amount of effect which is present. So this is definitely a suggestive of glaucoma. I just have quickly tell you about different types of OCT reports. But remember, all these reports have the same kind of color coding and representation of RNFL thickness. So you have to look for the double hump pattern, you have to look for the hourglass pattern in this kind of images, and look at how it is deviated from the normal. So always it is represented with the normative database. And most of the OCT equipments will have normative database from the age of 19 years. If you have any patients who have to get an OCT done less than 18 years of age, then the normative database is not going to be present, but it can actually form as a baseline for the progression analysis. So I have not covered about the progression analysis in the presentation, so probably we can take it up later. I thought this information has to go in everybody who's looking at the imaging. So OCT spectrometer is actually one tool which has both anterior segment OCT, posterior segment OCT, and also the angiography in one single unit. So it can image the anterior segment, it can image the posterior segment, and it can also do an angiography in one single instrument. So this is an advanced technique with OCT. Just to brief you on OCT angiography, so we must have heard a lot about the angiography which is used in diabetic retinopathy and other vascular disorders. But in glaucoma, it is now picking up the angiography. So what happens here is the vasculature, the vessel density is getting reduced in glaucoma. So you could see that this is a healthy eye where the vascular density is much, much better, and it is getting reduced in glaucoma suspect, and it is almost very less in glaucoma. And this is because we do not know whether it is because of the reduced ocular blood flow, this vascular density is lesser, or is it because the vascular density is getting lesser, the ocular blood flow is slow. So we could see that there is an reduced ocular blood flow in glaucoma, which is now picking up its diagnostic ability in glaucoma diagnosis. So this is an advanced tool which is currently in practice with glaucoma diagnosis. So just to summarize, in glaucoma, we have the structural loss and also the functional loss. If we correctly or appropriately use the techniques, then we will be able to diagnose the condition at a very early stage and preserve the vision of the patients. So to take home message, it is very, very important that we examine the patients with all the possible techniques so that we avoid missing the serious conditions like the sight-threatening glaucoma or even life-threatening pathologies like tumors, which can even be picked up with just a fundus photography. So enhance your practice by providing a preventive care. And remember, all these investigations should be interpreted in clinical correlation with the clinical findings. It should not be interpreted alone, but the progression analysis can be done even with the clinical imaging tool. Thank you, and I'm open for any questions.
Just a minute, Rashima ma'am. We are just unmuting Jemima ma'am.
Hello?
Yes, ma'am.
Yeah, before Jemima comes, let us not waste time. I have my question. What gives the double hump image, Rashima?
What is
What gives that double hump image?
what gives the double hump?
Yeah.
So the double hump is actually the neuroretinal rim thickness. Okay, as I said, the egg yolk and the egg white. So it is about the neuroretinal rim. So we said that inferior rim is thicker when compared to the superior nasal and temporal. So it is just putting across the thickness from temporal, and it goes to the clock cover, and it again comes back to the temporal. So temporal part, and then superior, and then nasal, and then again inferior, and then nasal. So it goes like this, and then temporal. So the inferior and superior will look like the double hump, the hump of the camel. So that is the thickness pattern arrangement in the nerve fiber layer on the neuroretinal root.
Thank you.
Again, she's muted. Yeah. Yes, Jamina.
Can you hear me?
Yes, now.
Okay. There is one question from Mr. Gopinath.
Yeah.
So he has asked that, just a minute. He has asked that handling and assessing the optic nerve head using a 90D is tough unless the clinician has a good hands-on. So
Yes.
what are the initial practices to be done by a student or independent practitioners who wish to learn 90D?
Okay. So when you have a slit lamp in hand, you can actually use the 90D or the 70AD lens to evaluate the optic nerve head. But to get the hold of the lens and to look at the optic nerve head, it really needs an experience. Okay. So initially, what I say is dilate the pupil so that you will have a good idea about locating the optic nerve head with 90D. So initial, when you start with evaluating the 90D, evaluating using a 90D, use a dilated pupils and start working on it. Or otherwise, first learn about the optic nerve head and its arrangements using a fundus photography. That is easier, much easier when compared to a 90D. And then look at the same eye with the dilated eyes with the 90D and practice with undilated, keeping the room's lights off so that you will get the pupillary dilatation and you can still use that amount of dilated ability to look at the fundus.
Thank you, Rashima. There's one more question from Preeta. So excellent presentation. She has asked that the TD-OCT is good enough to diagnose glaucomatous optic nerve and retinal RNFL changes, or do we have to have SDHRT?
Okay. So I specifically did not use the report of TD-OCT because it is almost 2 decades now, 2 decades old now. So we are advancing with the technologies. It is spectral domain, and now we have the swept source OCT coming in play. So when we have an advanced techniques, if the person is still using the older technique and you want to follow it up, so you are still be using some techniques like the limitation with the TD-OCT is a motion artifact. Okay, so even if just the person blinks, you may lose large amount of data. And if there is a small eye movement, you may lose large amount of data with a time domain OCT. So in that case, if you really want to enhance the practice, it is better to go ahead with the spectral domain OCT so that you can look at the details much more deeper, and also you will not lose the data. The patient cooperation need not be very high as in case of a time domain OCT.
Rashima. Apart from this, I would request all the viewers to fill in the registration. There's a link given for feedback form. So it would be good that if you all could fill up the feedback form and give. Apart from that, I don't think there are any other questions so far. If anyone has any questions, you can put it in the chat box immediately so that you have the expert advice.
So we had around the 20 questions listed down in the pre-test questionnaire, just to understand people's knowledge about glaucoma and also the knowledge on the utility of the imaging tools in glaucoma. We had a varied response. I think if that questionnaire has been filled back again in the post, we would see the transformation from what was there at the baseline and what was there after the lecture. So probably, I think we do not have a post test. Probably I can discuss about the questions and look at the responses and give the answers for each question if that is allowed. Okay.
That will be good.
Yeah. JGP sir, can you just project the questions first? Probably. Yes. Oh, it's getting filled up now. Right. So this was a very simple case, straightforward case of primary open angle glaucoma, because there was an increase in intraocular pressure, and also there was a structural loss which was seen, and a functional damage. So it is a primary open angle glaucoma. And next question was on the management for that particular case. Which imaging technique would be the ideal tool? Of course, most of you are right here. It is the posterior segment OCT, because there is a structural loss which is seen. So if you want to evaluate that, then you have to go ahead with the posterior segment OCT. Can imaging techniques be used independently to assess the progression of glaucoma? Yes. Yes, it is. Because you have progression analysis softwares. I purposefully did not cover it in the today's lectures, because if I talk about the progression analysis, it is going to be a separate lecture altogether, and there will be a lot of confusion. I thought initially let us start with diagnosing, and then for the progression, probably later we can take a session. So it can even be taken as an independent tool to assess the progression, because there are guided progression analysis softwares with these tools to look at the progression of glaucoma. And the next one is the 5 R's to be assessed in optic nerve head. So yes, I could see scleral ring, neuroretinal ring, retinal nerve fiber layer, region of peripapillary atrophy, and region of optic nerve hemorrhage. Absolutely right. So many people have written down about the ring, and I think after the discussion about the optic nerve head analysis, probably everyone would agree about the 5 R's and its importance. In case of primary angle closure suspect, which imaging tool is ideal for close follow-up? Oh, it's written over there. It's an angle closure suspect, so anterior segment OCT is the ideal one. True. All of you are right on that. Most of you are right on that. Nerve fiber layer thickness assessment in its OCT is best depicted as you have the sector average, which is present as a quantitative measure. You have a thickness asymmetry graph, thickness graph, and everything has to be is presented over there for nerve fiber layer. And most of you are right with that answer. Is refractive error assessment important prior to any imaging procedure for glaucoma assessment? Yes, it is. Because as I said, the myope and hyperope assessment, it is important to look at the refractive error and then clinically correlate with the fundus findings. And also, all the imaging tools use the magnification factor. So it is important to incorporate the refractive error information before you start with any imaging. Yes. Yes. This was a tricky question which I purposefully did it. A myope of 5 diopter and a hyperope of 5 diopter with a cup to disc ratio of 0.6. Most of you have written as a myope of 5 diopter, and I think everyone will disagree with it now that it is a hyperope of 0.5 diopter and 0.6 cup to disc ratios at very high risk glaucoma, because it is a smaller disc with a larger cup, so there is definite glaucomatous damage which is present. Yes. Next question. In case of tilted disc, which posterior segment imaging tool is ideal to be used? Most of you are right. It is the optical coherence tomography, because HRT and other things, it is very, very crucial, and you do not have the normative database also for that. In case of severe glaucoma, this I actually didn't cover in my presentation. In case of severe glaucoma at the advanced stage, almost the structural damage is present, which means there is a 0.9 cup to disc ratio and the neuroretinal rim is almost lost. So when it is almost lost, how do you assess with an imaging tool? It is not going to be helpful. So it is important that you assess the functionality. You need to use a functional assessment. So you use a static perimetry to follow up. So if it is going to be an early glaucoma and moderate glaucoma, use the imaging tool. If it is going to be an advanced glaucoma, don't depend on the imaging tool. It is not going to be helpful at all because almost 100% damages occur. So it is important that you go with the functional assessment, like using a confidential field or the optics.
Thank you. Thank you, Rashima. So it was an excellent presentation coupled with the, quiz in the beginning. So where we were able to really, judge how much knowledge we have. And I'm sure that after the presentation that everyone's knowledge is enriched. And a few more questions are there. There's a question from one Mr. Devi Kumar. The data which the OCT compares, whether is it a global data or an Indian data?
That's right. So the OCT database has global sectors of data, but you can choose which ethnicity you want to. So you can even choose the Caucasians, you can use Asian data. So it has an option of selecting the database. So even if you're seeing a foreigner, you can choose that its ethnicity and compare the database. So OCT machine has the different ethnicity database in it. So you can choose.
There is another question from Preeta. The non-magnetic fundus camera images have a lot of white reflections, which makes it difficult to ascertain few retinal changes. So what is your advice with respect to looking for subtle changes in those images?
So it is up to the imaging technician now. So what I wanted to tell you is when you're imaging the fundus camera, make sure that the pupil has a maximum dilatation capacity, or otherwise use a darker side of your clinic or a darker room, or you make the patient sit opposite to the, if the light should be from the back so that the pupils gets dilated and you have a maximum view of the fundus. And make sure that you make a subtle movement and you avoid the reflex from the retina so that you don't get that whitish flash reflex from the fundus. So it is absolutely on the technique of imaging the fundus photographs.
Thank you. There's one more question. With swap field confrontation, can we diagnose early glaucomatous changes?
With
swap field, I think maybe they're referring to the field test swap. I'm not sure.
Yeah, I did not get the full question. With swap?
SWAP, with swap field confrontation, can we diagnose early glaucomatous changes?
Okay. I just want to rephrase the question. Probably the person wanted to know whether it is the swap technique in static perimetry be useful in diagnosing the condition earlier.
Yeah, so, I think that is what they meant.
Yeah. Probably 10-15 years ago, swap was actually into practice, and most of them said that swap using that technique, you can pick up the glaucoma damages earlier. But now there are a lot more of research which is into swap, and they said it is not so. So it is better to use the normal perimetry itself. And in normal perimetry also, there are few amount of advancements which has happened now. So instead of just the 24-2, you can also have the central 10 points, 10-2 points also been incorporated. So that can be a better tool than the swap.
There is one more question. A person wants you to simplify how to calculate the cup disc ratio.
Okay. So let's take an example of the disc diameter as a 1 rupee coin. Okay. So of that 1 rupee coin, how much is the cup which is occupying? So if you take this as 100, so the cup is occupying how much percentage is what is the cup to disc ratio. So for the cup to disc ratio, you need to mark the cup boundary. So the cup boundary is, earlier we were looking only at the color. So how much is the yellow? But that is not the right way of doing it. The right way is looking at the contour. There is a blood vessel which is bending. So just go around the blood vessel bending, just mark that. So say that this is going to be the disc diameter and you are going to mark the cup like this. So if you take this as 100, how much is this occupying is what is the cup to disc ratio. So out of 100, how much is this? Whether it is occupying 40%, whether it is occupying 50%, whether it is occupying 60%. Is that okay? Or
I think you explained this clearly earlier also. So I don't know whether this is enough or the person is expecting anything else. But this is the thing, yeah. The representation you gave with the picture of egg and everything was very clear to understand for any beginner also. Thank you so much. There is also another question by Preeta. So in the pre-registration questionnaire, in question 1, there were obvious changes noted, that is 0.6 cup disc ratio and inferior nerve fiber loss. But the visual field report showed normal and a nasal step defect. So, so how reliable is CETA? And in such cases, again, she's asked about swab. Is swab better?
okay. So in this particular case, there was a nasal step which was seen. So probably the 0.6 for that particular patient may be normal. So as I said, I have not mentioned about the refractive error of that patient in this particular case. Okay, the patient could be a myope also. The 0.6 with just an inferior defect could even cause only a nasal step, or it could even be an arcade if it is going to be a hyper or a smaller disc. So I did not mention about the refractive error here in this particular case. Definitely, Preeta, earlier people were using about swab, but now it is not at all in the practice. It is only the CETA standard which is currently in place. Along with the 24-2, we are incorporating the central points so that you could even get much more valuable points for the progression analysis with visual fields.
Thank you. There's one more question. In advanced glaucoma, you mentioned to monitor with static perimeter, like a Humphrey, but the patient is already having tubular fields. What is to be followed in field reports in follow-up?
So in cases of tubular fields, we will not be able to do the 24-2. So it is important that we go into the central 10 degrees. So what is the usable vision which the patient has? You have to be evaluating that. And if there is any progression, you need to change the treatment protocol. You need to go ahead with the surgery and things, right? So it is important to know how much is the field of vision is present for the patient. So 24-2 is definitely going to be not useful. So you have to go ahead with the 10-2 or otherwise the macular fish. So that is what is advised in case of advanced glaucoma.
So thank you so much, Rashima. I think that's it about the questions.
One more.
If there's anyone else who has a question, they can ask because we still have time, I guess.
Yeah, I have a question. What is the significance of OCT angiography, and what is the risk involved with the dye?
Okay, OCT angiography, as I said before, I was talking only about a non-invasive technique. So there is no dye injection in this OCT angiography, like PFFA. So this is a non-invasive technique and there is no dye injection in this. So there is no problem with the patients.
So how is it done?
So it is imaged as the regular OCT protocol, but you have a different scan protocol to do this, and it gives the vasculature patterns. Because currently, it is just stepped into the clinician or the clinical management now. So very recent it is. There is still debates on whether it should be used for glaucoma management or not. Still debates are going on, but people have started working towards OCT angiography, collecting the data and looking at the differences in glaucoma and normal eyes. It's completely non-invasive, and it just in, say 1 or 2 seconds you finish the protocol and then you get the results.
Rashima, just I want to know, since there are practitioners are there, independent practitioners are there. In reality today, in fact, we don't have OCT. In fact, you say that OCT is the best to hold, but I think OCT costs not less than $500 million. And what is your vision for independent practitioner, especially to ensure appropriate referral and appropriate follow-up in their practice?
So that is the reason why I was concentrating more on optic nerve head evaluation using a disc photograph, because most of the audience today would be independent practitioners or a clinician who may have the fundus photograph in hand. So that is the reason why I concentrated on the fundus photograph. So look at incorporating a fundus photograph for all the patients. Don't say that I'm not going to do it. I'm going to do it only for patients who are complaining of difficulty of sight vision or complaining of difficulty of something else. So it is important that you incorporate that as one of your comprehensive eye examination itself and take fundus photographs for everybody if it is available. And there are companies which are actually giving the fundus cameras as a hiring cost. So probably practitioners can also use those facilities, get the fundus cameras, and then I'm not for any of the manufacturers here. I'm just giving you a thought that this is also available. So you can hire the fundus cameras and then use that in the practice for the preventive care, because we should be moving towards the preventive care now. So I agree completely that OCT is going to be a super expensive equipment. But for today's lecture, I incorporated OCT because you may get patients who have the OCT report in hand and they may ask you whether this is normal or not. So for that interpretation, for that review, I incorporated the OCT HRT into this. But definitely, I agree, sir. Not every practitioner can get a OCT in hand. But I know few of the persons are running a diagnostic center. So probably you can refer your patients to the diagnostic center and ask the patient to come with a report. So that will be enhancing your practice to the next level. Is that okay, sir?
And can you give some clinical tip on which are the cases we should refer, which are the cases which we can defer? Maybe that will be of help.
Okay. So if you have a patient, say, for example, patients with a family history of glaucoma, and you see that the optic nerve head is healthy, intraocular pressures are fine, the refractive error is fine, you can just follow up the patients regularly. So you don't need to refer it. But if you see that there is a cup to disc ratio is asymmetrical between the eyes, still it is one eye is 0.2, another eye is 0.4, still asymmetrical. So it doesn't look normal to you. It's better to get one opinion at least from an ophthalmologist and then follow up the patients with you if everything is fine. And the other thing is if the IOP is borderline, so it is important that you get one baseline structural assessment at least, which means one OCT and one visual field if the IOP is borderline, so that you will know in the future follow-up whether there is a progression which is present or not. So these are the important conditions where the clinicians should be following up the patients. And all patients above 50 years of age, it is important to have a baseline documentation of the fundus photograph. It is very important because glaucoma is actually an aging disease. It doesn't mean that we will not get that. So there is a possibility that we may also get it. So it is better to have a baseline documentation and compare it to see whether there is a progression which is present or not.
There are two more questions, Rashima. So there's one person who has asked, Saravanan, is there any tool to assess for apoptosis? I think he's meaning the cell death.
The cell death. So I'm completely unaware about it. Probably in research it may be, so not in a clinical practice.
Okay. And one more question from Preeta. Please throw some light on changes in NTG and OHT. Okay. Normal tension glaucoma and
right. So, so in the normal tension glaucoma, IOP is normal, but there are changes with the optic nerve head, there is optic nerve hemorrhage, and the visual field is actually progressing very fast in case of normal tension glaucoma. So there is a possibility that the target pressure which the consultant, the ophthalmologist sets is going to be very, 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 very low for that particular eye. Why this happens is because not every eye has the capability of this, taking up the intraocular pressure in a similar way. What is normal to me may not be normal to you. So 21 may be normal to me, but even 15 is abnormal to somebody, which means the eye is not capable to take that pressure even. So that is why there is a damage which is happening in normal tension glaucoma. In case of ocular hypertension, the rigidity of the eye is good. So whatever be the pressure, the eye is so rigid that it can actually withstand the pressure. So that is what is happening in ocular hypertension. But these ocular hypertensives can actually progress to glaucoma. And there are even cases where they just remain as ocular hypertensives and they never progress to glaucoma at all. Okay? And there are conditions where normal tension glaucoma diagnosed and within 5 years they even go into the stage of advanced glaucoma. So these are all like the eyes behave very differently. Not all the eyes are equal. So you need to have a very, very close follow-up in cases of normal tension glaucoma because it is progressing faster. In case of ocular hypertension, it is only 6 monthly. In case of normal tension glaucoma, even 3 months once you need to evaluate until you feel that the intraocular pressure is stable enough, there is no progression with the visual field. Then you can increase the follow-up duration to 6 months.
Thank you, Rashima. So Krita has told I meant OCT changes. I think she wanted to ask about OCT changes for normotensive and ocular hypertension, but I think it is very good that it's given a good idea for the viewers about both.
Yeah, in normal tension glaucoma and open angle glaucoma, it is going to behave the same in ocular OCT. The only thing is in normal tension glaucoma, you will also have the hemorrhages, and there is a possibility that the sectors will miss the information because of the hemorrhage. Okay, so there is a possibility that there could be a thickening which is seen at those locations. So you need to really read with caution. So as I said, the three different colors, the red, green, and yellow. Apart from it, there can also be a color white in the picture. The white indicates there is abnormal thickening, which is outside the 95% of normals. Okay, so this thickening could be because of the presence of any drusen, okay, or any abnormality in the which is actually giving an elevated lesion over the optic pancreas. In case of normal tension glaucoma, there is a hemorrhage. There's definitely a hemorrhage which is going to be there on the optic pancreas. In that case, there could be a complete loss of NFL which could be seen. But if the hemorrhage regresses, okay, there is with treatment, and you could see a change that the OCT values are becoming normal there. Okay, so you need to take the after the regress, what is the baseline? That has to be taken as a baseline for the follow-up progression analysis. That's the only difference. We do it for NTG and POAG in progression analysis. Otherwise, the interpretation is going to be the same.
Okay, thank you, Rashima. I think that's about the questions. There's one more. NCT has got lesser sensitivity but useful in lot of clinics. Suggestion in this.
Yes, when you have camps or any things like outside where you do not have a facility for an invasive procedure, in that case, NCT can be useful. But the NCT values are actually highly variable. So I usually say that you don't just trust with one value. Always take 3 measurements and make sure that there is not a lot of deviation between the measurements. Say if it is 15, 16, 16, then it is almost closer. Okay, and one value is 15, another value is 21, another value is 14, which means there is so much of fluctuation. You need to repeat the measurements and then decide on the final cutoff. In those patients, I prefer that we do the applanation tonometry and take a call about the pressures. So NCT, yes, it is definitely helpful for the clinicians when you go in for a larger camps and things, but it should be taken with a caution. There is a large amount of variability with the NCT measurements. Even the positioning of the chin, how the closure of the eyelids, all this is important in taking the measurements with NCT.
Thank you, Rashima. A question from my side. So now with the coronavirus, would you advise everyone to use NCT rather than applanation?
No. We are not advising using an NCT here because an NCT, because it is going to use the air pulse, there is a possibility of aerosol generation. So we are not advising for the non-contact tonometers, which is using an air pulse. But there is also another tonometer called as diatom, so which is done over the lids. Okay, it's like a home tonometer. So that can be used, or otherwise an eye care tonometers, which is going to have a very pointed pressure applanation, that can be used, but not the tonometers which has air pulse. I think Dr. KK was also mentioning one of the question 2-3 weeks ago.
Okay, so thank you so much, Rashima, for a wonderful session. And
Thank you all for giving this opportunity to deliver the information about the clinical imaging.
and
Thank you so much.
it's a great honor for us to have with us Dr. KK to join with us. And we would, from OATN, we would like KK to give the word of thanks.
Thank you, Rashima. I think, as usual, enlightening, and you are a great teacher. And we made it short span. Actually, most of them would have understood the best way, and really a given hope for expansion of all the optometric clinic to venture into diagnosis of glaucoma. And I always well aware that glaucoma diagnosis by optometrists is a real takeoff for optometrists itself. We also know what is the consequence if it's been missed. And many a time we realize that people tend to come to tertiary eye care center very late with all the advanced scenarios. I always feel it is not only diagnosis, it is also important with all the knowledge and probably equipment down the line. As an optometrist, we can play a huge role in follow-up. After all, optometrists ensuring good compliance of the medication and ensuring that they undergo proper tests at the appropriate time. And ophthalmologist takes care of the management part of it. I think wonderful that it is a great trigger, and hope many of the listeners probably will be thinking of how to apply it. And maybe many queries will come to you or to OATN to see how this transformation is possible. And thank you all for wonderful questions. And thank you for the moderator, wonderful Jamima, for making this more lively. And thank you, Purnima and Jyoti Balaji, as usual, giving the great technology support. And thank you all senior members and the president. Thank you all.
Thank you so much.